Hello.
It's Kam Shajania here. I'm just waiting for Dr. Palapu to join. If she's on call right now and on service, so if she doesn't join in the next minute, I'm going to introduce Dr. Baldwin. I'll just give her one more minute, and as well, we have time for other people to join in.
Can I be heard right now?
Yes.
Okay, perfect.
Everyone can hear you, Dr. Baldwin, so watch your language.
I'm just looking to see if there are any names I recognize from when I was training.
Well, there's Dr. Ainsworth I see here.
Yeah. I think Dr. Werb is nephrology, if I remember correctly.
Dr.
Nice.
Van Holt, the new rheumatologist in Kelowna.
Correct.
Of course, yeah, there's more.
And Nora Cummins, Dr. Cummins. Great, I remember, and Dr. Ramji. I remember all these people. It's nice to see.
Dr. Bowie is one of our new rheumatology fellows as well.
Hi, Corrie.
Hi. We're just counting down the days till you come back to the island.
I think we can go ahead and get started then.
Sure. Okay. So thanks
Wait,
for.
I was going to
Oh,
introduce.
sorry. Oh, sorry.
Dr. Baldwin is a rheumatologist who trained in Vancouver, also did some additional training in vasculitis and pregnancy and rheumatic disease. Sadly, she moved to Alberta and worked there for a few years, where she also did vasculitis and pregnancy and rheumatic disease. And she was very smart in moving back to BC, particularly to Victoria, where she also runs a vasculitis clinic that's connected with our vasculitis clinic here in Vancouver. Dr. Baldwin is a very good speaker, and I had the misfortune of debating Dr. Baldwin earlier this year in February, where she won the debate, and I, of course, was part of the losing team. It's a pleasure to hear you speak on vasculitis, large vessel vasculitis today. Thank you.
Thanks. So thanks for having me. So today we're going to talk about diagnosis and treatment of GCA. And I have to give acknowledgements to our colleague, Shannon Galway, who provided some of the background slides on PMR. And you can't really talk about GCA without talking about PMR. Okay. How do I get this to go forward? One sec. Okay, here we go. I don't have a lot of disclosures, really. And this is beautiful Oak Bay in Victoria. So if there are any trainees on here who are wondering about leaving the bigger center to go to a not so big center, but still a big center that has a great lifestyle like Vancouver, Victoria is the place to be, okay? So we're quite busy in Victoria. We have all of us have our outpatient clinics, and we also provide callback to Victoria General Hospital and Royal Jubilee Hospital. I run a vasculitis clinic out of the Victoria Arthritis Center. And right now we're working on having a formal supported call service for the inpatients. So my objectives right now are to review the updates in the workup and diagnosis of GCA and to briefly review the role of imaging in GCA, but majority of this talk is going to focus on the evidence underlying the treatment of GCA. So I'm going to take a step back and look at vasculitis in general. So just a reminder that the current nomenclature for vasculitis which was updated in 2012, is to divide it into large vessel vasculitis, medium vessel vasculitis, and the small vessel vasculitides. And the small vessel vasculitides include your immune complex vasculitis, so cryoglobulonemic vasculitis, IgA, and hypocomplementemic. We don't forget about anti-GBM, and also the ANCA vasculitides. And there's a whole other list of nomenclature for variable vessel vasculitides and vasculitides secondary to other causes. So today we're going to focus on the large vessel vasculitis, predominantly giant cell arteritis, which is some may or may not be the same disease as Takayasu arteritis. It's actually an area of debate. And GCA is the most common form of vasculitis that we see. So that's where we're focusing today. So these are the manifestations of large vessel vasculitis. So remember that it's a biphasic disease. So typically we think it starts with systemic symptoms. So your fevers, chills, night sweats, anorexia, weight loss, fatigue. And then later ischemic symptoms can develop, whether that be in the form of a temporal arteritis, in which you get headaches, scalp tenderness, jaw claudication, and potentially vision loss, or whether it be from aortitis that causes subclavian artery involvement akin to Takayasu's, where you can get claudication, where you can get ischemic chest pain, postprandial abdominal pain, or renovascular hypertension. And that's true of both GCA and Takayasu's, that they can present similarly. And in some cases, when patients present with aortitis, and perhaps they're in their 60s, there's also, although they don't meet the criteria for Takayasu's, it's also possible that they had this diagnosis and this disease process going on years before, and that this is actually the end stages of Takayasu's. So there's debate as to whether or not they're actually two different diseases, but we won't go into that in too much detail today. So depending on your symptom presentation, your differential diagnosis for GCA or large vessel vasculitis is going to change. So temporal arteritis, I want people to think of it as a syndrome. So yes, we know it is commonly a manifestation of giant cell arteritis, but it can also be a manifestation of other entities. And I've seen it in microscopic polyangiitis, for instance, that they have GCA as a manifestation, predominantly with the claudication of the jaw. So, you know, you divide it into the vasculitides and the non-vasculitides. You can divide it up any way you want, but in terms of temporal arteritis, think about obviously GCA, but also think about GPA and the other vasculitides. You want to think about TMJ pathology as an inflammatory cause, so rheumatoid arthritis in the jaw, gout in the jaw. Infectious causes, so thinking of shingles, meningitis, sinusitis, dental abscess, erysipelas. I've seen all of this, like truly. Malignant causes, so tumors, neuropathic causes, so trigeminal neuralgia, or nerve entrapment, such as occipital neuralgia. I had one of those in my office today. And then thinking of other entities as well, for that headache, for that high CRP. With aortitis, similar, you want to think of the primary causes of vasculitis and secondary causes, and you want to think about the vasculopathies more often in this setting. So with the primary vasculitis, it can occur in GCA TAC, but also GPA, sarcoid, Behçet's. IgG4 disease is more of a peri-aortitis, but it's on the differential. And, you know, we see aortitis more commonly in Angst-Bond. We see it in RA and lupus, and also in IBD. So other secondary causes, so obviously infectious, so TB, syphilis, Staph aureus, HIV, hepatitis has been reported. Mentioned the IBD, and then lymphoma. When we think of vasculopathy, you want to think about predominantly atherosclerosis. Like, this is the most common thing. And then fibromuscular dysplasia, Marfan syndrome, or EDS, depending on how they present. So like I said, you can't really talk about GCA without talking about PMR. So again, I want people to think of this as a syndrome that can occur primary on its own or secondary to other entities. So it's manifested as aching and stiffness in the shoulders, the hip girdle, neck, and torso. It tends to be worse in the morning with prolonged morning stiffness. These patients can't put their hands above their head. They can't get up from a sitting position. Typically, we think that the onset is quite abrupt. So they go to bed fine, they wake up the next day, they're worse. But we do see gradual onset as well. The pattern is also typically bilateral and proximal. Okay, so if you can get mild distal symptoms such as knee and wrist involvement, but when you are getting those manifestations, you really need to think about other entities such as rheumatoid arthritis or a PMR onset rheumatoid arthritis. While it is bilateral, sometimes we'll note that people have unilateral onset and then it spreads. And my theory on this is just that, you know, there's a lot of rotator cuff pathology, a lot of injuries, and perhaps it starts in those susceptible joints first. We mentioned their functional limitations. Often it's associated with malaise, fatigue, depression, anorexia, weight loss, or very low-grade fevers. GCA is seen in about 16 to 21% of patients with PMR, and about 40 to 60% of patients with GCA will also have a history of having had PMR. So whenever you see PMR, always think, could this be giant cell arteritis or another vasculitis, or could this be rheumatoid arthritis? And I have seen a lot of PMR-like symptoms as a presenting feature in our ANCA vasculitides as well. So, but unlike GCA, if you treat PMR with just 15 to 20 milligrams of prednisone, not more than that, you're going to get complete resolution within 24 to 48 hours. If you don't get complete resolution, then you need to think of other entities. And that doesn't mean that you necessarily treat for other entities. That might mean that you monitor them for a little bit longer, you might order additional tests, you might do your taper a little bit slowly, or you might follow them a bit more closely with anticipating that the results or the underlying disease process will flare as you taper the prednisone. So what are the predictors of GCA in our patients with PMR? So a new onset of headache, had an onset odds ratio of 13.6, age of onset less than 70, abnormal temporal arteries, raised liver enzymes, but the big ones that I want you to think about was jaw claudication and that new onset of headache. Amaurosis was only seen in patients with GCA, not with PMR. So there are 3 subsets of patients in this particular study that were considered to be very high risk of arteritis. So those were patients with recent headaches, abnormal arteries, and onset of greater than 70 years at onset of symptoms. Patients with new headache, jaw claudication, and abnormal arteries, and patients with new headache, jaw claudication, and abnormal arteries greater than 70 years disease onset. Oh. So somehow my formatting is not working with this computer. Great. So I just wanted to review classification criteria for giant cell arteritis. So the ACR criteria, which we all know and love, are classification criteria. So these were developed through specialist consultation in a meeting. And what they did is they took they had a pool of patients with known vasculitis of various etiologies. So you had your PANs, you had your Takayasu, you had your GCA, your Wagner's, and they were trying to distinguish giant cell arteritis for other forms of vasculitis. So this is not used for diagnostic purposes, this is classification purposes. So it doesn't distinguish a person with a headache due to GCA from any other cause of headache or the normal population. So useful, but not reliable. So age of onset greater than 50, and I'm gonna just emphasize that I generally see GCA in people older than 60, but the classification was over 50. New headache, temporal artery abnormality, be it tenderness to palpation, decreased pulsation, an elevated ESR, or an abnormal arterial biopsy that shows vasculitis with mononuclear cell or granulomatous inflammation, usually with giant cell. So high sensitivity and specificity when distinguishing these patients from other types of vasculitis, but hugely limited. So it doesn't take into account visual symptoms, doesn't take into account jaw claudication, which we know is a strong predictor, doesn't take into account any other lab abnormalities like CRP or platelets. It also doesn't take into account any other manifestations of GCA other than temporal arteritis. And aortitis, for instance, is becoming increasingly recognized as a common manifestation. So in 2016, they developed revised ACR classification criteria for GCA to try to address some of these limitations. And this is optimizing the classification criteria is actually an ongoing process. So they're doing it yet again. And so what they decided was that you had to have age of onset greater than 50, excluding other causes, that you had to have new localized headaches, sudden onset visual disturbances, PMR, jaw claudication, and abnormal temporal artery, and you had to have a minimum of 3 points. At least one of these had to be within this domain. And then domain 2 was unexplained fevers and or anemia, ESR greater than 50, and a compatible biopsy. So I just want to emphasize this has not yet been validated, but it has been used in some studies. So just to emphasize again, no diagnostic criteria, classification criteria for research purposes only. And temporal artery biopsy still remains a gold standard, but even this is fraught with problems. And I kind of say this, that it is the gold standard because I think it's the gold standard across all centers. So some centers now have the ability to do temporal artery ultrasound, which I'm going to talk a little bit about. But this isn't readily available at all sites, even though it's a fairly non-invasive test, and we'll talk about that. The recent EULAR criteria actually does accept it as a gold standard, but it really is site dependent. So this is Oak Bay near where I live. So another plug for people to come and work and practice and live in Victoria. And then it's not moving. Okay, there we go. So I wanted to bring up some cases. So the first case is a 72-year-old female with hypertension, dyslipidemia, or diabetes. And she presents with headaches, scalp tenderness, PMR, and malaise. So she has some abnormal labs, normocytic anemia, thrombocytosis, her CRP is high. And she's diagnosed with GCA, started on 60 milligrams of prednisone, and referred to you urgently. Okay, so I wanted to ask the audience, and I guess we'll do it with the chat. Does she need a temporal artery biopsy? I can't see the chat, so maybe you can see the chat. There we go.
Yes.
Yes. Thank you, Stephanie. Oh, hi, Dr. Palaku. Okay. So let's see. Okay. So treatment, the current prior evidence, I guess, would show that treatment decisions are not actually influenced a great deal by temporal artery biopsy in most cases. And there's some evidence that biopsy is predicted as unnecessary in about 40% of cases. So there's some data to look into this. So this particular study was done by general surgeons. And this was a retrospective study of a consecutive cohort of patients who underwent TAB between 2014 and 2016 in the UK. So they collected patient demographics, lab parameters, inflammatory markers, time to biopsy, length of biopsy, and obviously the histology. And this is where that revised ACR criteria comes in. So they actually compared the 1990 criteria with the revised ACR criteria. And the ROC was used to evaluate the relationship between the two in the biopsy results. And performance of each score was used to predict biopsy results through the AUC analysis. So what they, at the end of the study, they came up with was a clinical tool that they developed, which they feel is useful for interpreting whether or not interpreting what to do with management. So this is just to show you that the revised score actually performed better than the ACR score. So including sensitivity and specificity, right? This is to show you, this is the proposed clinical management tool. So what they said is if you have a revised ACR score less than 2, then you probably don't need temporal artery biopsy or steroids. If it's 3 or 4, it does require confirmation, so they're recommending that you perform the temporal artery biopsy. If it's greater than 5, they're saying don't bother, no biopsy. Just treat, right? So just to show you these criteria, our patient, she was 72, so she meets the 8 criteria. She has a headache, so she gets a point there. She has scalp tenderness. She has PMR, so she's now up to 3 points. And she, I guess she has a CRP, but it doesn't really take into, and she's malaise, but she doesn't have any of their points. So actually, she comes up as a 3. And so you were right, those of you who said go for a biopsy, because according to this study, that they're saying, yes, indeed, it would be helpful. It needs confirmation. So this is another study, and this one was done by ophthalmologists. So what they did is they had a standardized questionnaire that they administered preoperatively to patients who were referred for suspicion of temporal arteritis and for the requirement of a biopsy. And patients were assessed and biopsied within 7 days of being referred. They all had bilateral biopsies. They all had a minimum of 2.5 centimeter length lesions. And they did a univariate logistic regression analysis to associate signs, symptoms, and serum markers with biopsy outcomes. And so they developed these clinical, these models. So they had a clinical model, they had a serum marker model, and then they have a combined model. So their clinical model was, the jaw claudication had a very strong odds ratio, and subjective description of anorexia had a strong ratio. They did a serum only, the ESR and the CRP and the platelets were all pretty comparable. And then they actually combined the two to see if it would improve things. So what you see here is you've got the blue line here being your combined model. The red line is this, the serum model, and then your green line is your combined model. And this is kind of the important piece, because what they did is they looked at the thresholds of various serum markers to see whether or not you could predict the biopsy results based on these parameters and perhaps avoid a biopsy. So if their ESR was less than 9, CRP less than 2, and platelets were less than 224, none of those patients had a positive biopsy. Whereas if you had a ESR greater than 90, CRP greater than 115, or platelets greater than 634, again, they all had positive biopsies. So it was only the people that were between those values that they felt would require a biopsy. So our person had a platelets of 465, so he lands in the in-between mark, and the CRP of 60. So again, even with this model, requires a biopsy. Would temporal artery ultrasound be useful in this case? Polling the audience. I agree. Com says, practically speaking, while it may not affect your initial diagnosis or treatment, nailing the diagnosis always puts you in a good position down the road. And I agree. Like, I think that's why I was highlighting that these studies are done by general surgeons and ophthalmologists, because you know, they're the ones that are doing the biopsy. So their bias is that they're trying to avoid biopsies, but they're not following the patients long term, right? So I think the answer to whether or not a temporal artery ultrasound would be useful is very site dependent. So it is useful. Predominantly, it includes, you know, first of all, you're able to evaluate the entire course of the temporal artery, but you're also able to get imaging of the carotids and the axillary artery. So you're able to get cross-sectional and longitudinal views, and the studies would show that, you know, you hear about this halo sign. So halo sign is this edema. So this is just fluid around the artery and a sign of inflammation. So that has an odds ratio of or a likelihood ratio of 3.64. The compression sign has a likelihood ratio of 75. Wall thickening and flow abnormalities, which is commonly reported in peripheral centers, and I see it in Victoria, is less helpful because our elderly patients have a lot of wall thickening from atherosclerosis. So this doesn't really distinguish the two. So in order to be able to see the halo sign and the compression sign, you need to be, first of all, fully trained, and it needs to be consistent. And that's one of the things that's a con of this particular test. So the pros are that you're able to avoid costly invasive procedures. And you're also able to assess the entire course, but it's very user dependent and it requires experience. And there's actually studies that show that you need to do at least 300 scans to be considered competent. They do take quite a bit longer, so 15 to 20 minutes per scan. But if you're not experienced, they're going to take much longer. So, you know, you need to have that consistent pressure, and it needs to be consistent with what other people doing this scan are doing. So there's courses available for this. In Victoria, we do temporal artery ultrasound, but I don't rely on them, and I try to avoid them because I often don't get the information that I need. Mo Barty, who does them in Vancouver, he's working with me to help develop a program here, but we need we're applying for funding to get the techs properly trained so that we can have a very consistent test. And you also need to compare it with biopsy and just make sure that, you know, for case control, quality assurance purposes, that you're to confirm at your site. So it takes a lot of training. And of course, you can't see the aorta. So just be aware of the scans that are being done at your center. And in Vancouver, this is not an issue. So somebody said, Dr. Murphy, please feel free. Okay, sir. Sorry, I thought it was a question. So visualization or CT MRI can help visualize the large arteries in the chest, neck, and abdomen. So you can see a lot of the anatomy. You can see the wall thickening, the stenoses, aneurysms, and it really allows you to tell and monitor for change. The resolution is much higher than MRI. So, you know, in my experience, it seems that we're okay with this in people who are over 65. So in GCA, this isn't an issue, but in our Takayasu patients, having serial CTAs is not really ideal. And so you are doing MRIs. And if you do them regularly, you know, every 1 to 2 years, that can be useful because you can monitor for subtle changes. You're not an account to kind of make up for that lack of resolution. There's little information about disease activity, and sometimes we see the thickening even when the patient's treated and asymptomatic, and it's really hard to interpret that because how do you confirm, you know, we have seen people deteriorate who have normal inflammatory markers as well. And, you know, stenosis is a end stage manifestation. So you can have inflammation, and then, you know, you treat that inflammation, and over time you get remodeling and scarring and narrowing, but that doesn't necessarily mean that the disease is active. So you really need to look at the whole picture ultimately. PET-CT scan can be useful for diagnosing and monitoring as well. And so the theory is the increased FDG uptake is associated with inflammation. We see that FDG uptake also in atherosclerosis is also the problem. The issue is that you don't get information on vessel architecture, and it's not protocoled in British Columbia yet. It's expensive, so it's not available for routinely available for us for vasculitis. It's only available for if you're looking for malignancy. But even when you know, occasionally I've been able to argue that I'm looking for malignancy, and even then it's difficult to interpret because the timing of the scan after you do the injection, correct me if I'm wrong, Dr. Murphy, but the timing is different for when you're doing it for vasculitis versus malignancy. So this is Willows Beach, another plug for any trainees who want to come and live and work in Victoria. So what treatment would you use for this patient? 60 milligrams of prednisone with a taper? Would you add methotrexate? And would you add tocilizumab? Are there any strong opinions in the crowd? No answers yet. Stephanie would use methotrexate. I'm with Stephanie. Okay, so again, would your decision change if she had vision loss? Would it change if she had poorly controlled diabetes or prior infections? I'm just laughing at the banter. And do you add aspirin? If so, what dose? So everyone always wants to jump to the tocilizumab data, but I'm going to start with the aspirin data first because there's actually been some changes in the recommendations here. So before, previous recommendations were to use aspirin in patients with GCA, and now they don't recommend it. So what is that old data or that old recommendation based on? So this is a retrospective study of patients in Israel diagnosed with GCA at 4 main hospitals. So they looked at 175 patients and they were able to follow up 166. So at presentation, they had those patients who were on aspirin already versus those who were not. And then at follow-up, they looked at those on aspirin with steroids versus those who were just put on aspirin alone, or steroids alone, rather. So not surprisingly, so patients with GCA already on aspirin had more cardiovascular risk factors, so that makes sense, right? Patients with GCA not on aspirin had fewer cardiovascular risk factors, but and 29% of them presented with cranial ischemic complications versus 8% in the patients who were already on aspirin. When they looked at follow-up, similar, the patients who were on aspirin obviously had more cardiovascular risk factors. That makes sense. They had cranial ischemic complications of about 3%. In the people that weren't on aspirin, although they had fewer cardiovascular risk factors, they had more ischemic complications. And so this is a systematic review and meta-analysis of this data, and this is what informed those EULAR criteria. And so they included 6 studies, and they looked at patients with severe ischemic complications, patients on treatment with aspirin prior to diagnosis, and patients who were put on aspirin at the time of the diagnosis. And they also looked at bleeding complications. And so in patients who were treated with aspirin prior to GCA, they found, based on these 6 studies, that there was no benefit. On patients treated with aspirin at the time of diagnosis in combination with high-dose steroids, there was possibly some marginal benefit, but it wasn't huge, and they didn't notice any bleeding complications. So this was part of what had informed the decision. So, you know, in my mind, if there's no real contraindication and the person has GCA, and perhaps this just reflects that I haven't had complications from it yet, so my bias. I start people on aspirin, even though it's not recommended. What about a statin? Do people start statins? So there's just 4 studies exploring the impact of statins on GCA, and they're all conflicting. So one study showed the use of statins did not reduce the likelihood of developing GCA. One study showed that statins may lower the incident risk of GCA. And one study showed that statin use prevented cardiovascular hospitalization rates in patients with GCA. And another study showed that if you use it up to 20 months, it can hasten the taper of the prednisone. So it's all super conflicting. And so the bottom line is there's not a lot of strong evidence for this. So this is just me sailing. I took sailing lessons, and I've actually joined a sailing team in Victoria. And it's me and a bunch of teenagers. So I'm pretty popular because I have a driver's license. So, and I could, yeah. So in terms of treatment, I think personally that methotrexate is the unsung hero. So I get to show you why here. So this is a study that looked at adjuvant methotrexate for the treatment of GCA. So this study was done in 2007 or published in 2007. And so they had 3 major studies in here, okay? So what I want to alert you to is that they used relatively low doses of methotrexate. So, 10 milligrams a week in the Jover arm, 7.5 milligrams to a maximum of 20 milligrams per week in the Spira one. And then this one, 15 milligrams per week. So there was a few cases in here where they were on 25, but these were underdosed. Well, underdosed in my opinion. In the rheumatoid world, we're using 25 milligrams of methotrexate when we can and need to. The duration was also relatively short. I mean, when you're looking at 18 to 24 months, patients can flare much later, and so that's a limitation. And then in terms of their definition of relapse was kind of all over the place, to be honest. So this is just to show you that, amongst all the patients who were on methotrexate versus placebo, that there wasn't a whole lot of difference. Vision loss, I noticed, was quite high, and I think this is more than I see personally in my population. And so this is looking at your risk of first relapse and your risk of second relapse. And so what this is showing essentially is you've got, if your dot is on the right side of the dotted line, it favors placebo. If it's to the left side, it favors methotrexate. And you can see that one study really drove a lot of that, drove the results of the study. But overall, it did favor methotrexate. And so this is just a similar way of showing the same thing. The methotrexate patients were less likely to flare. And I went ahead, for what it's worth, and counted the number needed to treat. So in order to prevent one flare, you need to treat 3.6 patients to prevent a relapse, and 4.7 to prevent a second relapse. So we always go straight to Tocilizumab after this, but just to review, there is actually evidence for ABATACEPT, and there's an ongoing trial going on for ABATACEPT in large vessel vasculitis. So this was a multi-center trial, newly diagnosed and relapsing GCA, treated with high-dose steroids, and they all got a loading dose of ABATACEPT, followed by randomization to either receive ABATACEPT, which is a CTLA-4 inhibitor, versus placebo, okay? And they also had their background prednisone taper. And it's a bit of an annoying study because you're not really comparing ABATACEPT to ABATACEPT. You're comparing ABATACEPT once to ABATACEPT loading plus a taper. So, and they were predominantly looking to make sure there weren't any complications, right? So they just wanted to show that it was safe. So it was a very small study, 49 patients, only 41 patients were randomized. And they got the infusion version of Orencia, or ABATACEPT. It's also available by injection, but this was on infusions. And then they were randomized at the 12-week mark to receive the infusion again every 28 days or placebo. And so this is just to show you their relapse-free survival. So number needed to treat for ABATACEPT was 5.88, but again, they all received ABATACEPT, and there's follow-up studies ongoing.
Corrie, can I,
Yeah.
before we go on to the next one, Drew asked about leflunomide. Can it replace methotrexate, for example, in GCA? It was mentioned at the ACR this year as another.
Yeah, no, it definitely can. Yeah, absolutely.
So you'd use it like methotrexate, basically.
Yeah, you would. I mean, the problem I find is that, you know, these patients typically have cardiovascular risk factors as well, and you're putting them on steroids, and leflunomide can cause hypertension. So I don't love it, but it's certainly an option. And it's an affordable option, right? Compared to these other, like tocilizumab.
And Stephanie mentions, and I didn't know that ABATACEPT was much more expensive than Tocilizumab.
Oh, that's a good point. I didn't realize that either. Okay, so they have looked at TNFs, and this is a study that looks at infliximab. And again, you know, 43%, their primary endpoint was % of patients relapse-free by week 22, so it was a short trial. But 43% in the infliximab arm, 50% in the placebo arm. And they did a similar study in patients with adalimumab. Neither of these studies were positive. So that's kind of, I find that very interesting. And, you know, I mentioned that GCA and Takayasu are similar diseases, but I've seen large vessel vasculitis, like a Takayasu-like picture, present in patients on TNFs already for psoriasis or IBD. Okay, so awesome. My slides are really not formatting great. So this is the GIACTA trial. So this is looking at an IL-6 inhibitor, Tocilizumab. And this is the best, one of the best studies we have in, I would say the best study we have in GCA. So patients, they had all patients with active GCA, and they had new and relapsing, I believe, and they were diagnosed on the basis of biopsy or imaging and high acute phase reactants. And then they were randomized, and the randomization was stratified based on their dose of prednisone into sub-Q placebo with a 26-week taper, so 6-month taper, so fairly short prednisone taper, sub-Q placebo and a 1-year taper. And then Tocilizumab every week with a 26-week taper, and Tocilizumab every 2 weeks with a 26-week taper. And so they continued that up to week 52, and then the study became open label. So their primary endpoint was sustained remission from week 12 to week 52 and adherence to a protocol-defined prednisone taper. And then their key secondary endpoint was sustained remission from week 12 to week 52 and adherence to protocol-defined prednisone taper for this applied to the 52-week taper. The primary endpoint was the 26-week taper. And they also looked at time to flare, cumulative steroid use, quality of life, and safety. And one thing, you can't see it, but what I wanted this study to show was that this study did not include patients with vision loss. And so this is just showing you the primary and secondary endpoints. And you're seeing number needed to treat anywhere from 2.4 to 2.6. And that's true of that's the weekly sub-Q arm, and the biweekly sub-Q arm was 2.5, 2.85. So actually better than methotrexate, but I'm not sure that it's much better. And again, it doesn't include vision loss. So this is just showing you the same thing, time to relapse, and the zone where the 26-week taper reaches 0 milligrams is here. And this is just showing the same data in just the new onset GCA patients and also the relapsing GCA patients. So this is the weekly arm of Tocilizumab here, and then your Q2 weekly is down here, akin to the 52-week taper. And this is just showing your cumulative prednisone or steroid dose. So you can see that in the weekly Tocilizumab arm and the Q weekly Tocilizumab arm, much lower doses of prednisone. And I just wanted to compare the number needed to treat for these studies. And, you know, the Tocilizumab is now available first line for patients with GCA. You can apply to pharmacare coverage for it, but it's expensive. And I'm not sure it's that much better. I'm not convinced yet that it's that much better than methotrexate, because recall that those studies had lower doses. They used lower doses of methotrexate, and they had patients with vision loss.
You know, it's interesting if you ask a bunch of rheumatologists about how they would treat GCA, even though we could use Toci right away, most of us are not. For example, if Barry gets GCA, we're going to treat him with prednisone and methotrexate, and then if he has a relapse, we'll try Toci. Is that what you would suggest?
That's what I do. Yeah, yeah. And there are a subset of patients that really don't need methotrexate either. I mean, to me, I haven't had a lot of complications on methotrexate, so if they're going to tolerate it, I don't see the harm. I can always discontinue it, right, down the road. But the prednisone, I'm wanting to get them off ASAP.
Asha writes, there was a subgroup of analysis of GIACTA that compared patients on Toci and methotrexate versus Toci only, and there was no difference. Interesting. So
she doesn't know the dose. Yeah, that is interesting.
Good that methotrexate. I think it's a good option.
Yeah. So some of you I haven't seen since I was a trainee. These are my current bosses right now. Eloise is pretty excited about methotrexate. Okay, so we did a study of our vasculitis clinic. So some of you may or may not know that both Natasha Degan and Daniel Ennis have a vasculitis clinic in Vancouver. I hope you're all aware of that. And I have one in Victoria. So I serve patients in the VHA area. And, you know, we wanted to know, after having this clinic for some time, you know, who was referring their patients and for what reason. And so I just thought I would present this data just so that really is a plug for our vasculitis clinics. So this was administered just to BC rheumatologists, and I'm toying with also sending it out to some of the general internists as well. But majority of the people, so this was just telling you who answered the survey. So we had a good respondents for people in various stages of their practice. Most of people are in community medicine and rheumatology anyways, and majority obviously came from Vancouver Coastal, but we had a good response from VHA as well in the interior. Majority of people are seeing, of the rheumatologists are seeing a lot of vasculitis patients. So, you know, 7% are seeing more than 10 per week. So that's probably Daniel, Natasha, and I don't know. But, you know, people are seeing 5 to 10 per week, right? Most common reason that people are treating is for a second opinion in difficult cases and for study enrollment. Reasons for not referring was that they were confident in their management and didn't want to duplicate services. So one of the, it's true, the vasculitis clinic is really good for a second opinion, but we are also part of CanVasc, the CanVasc network. So CanVasc has a CAN-based database where, you know, across Canada, whether you're in Montreal, Toronto, Halifax, Calgary, Vancouver, we all have access to this CAN-based database where we collect non-identifying patient information, so demographics, clinical symptoms, labs, imaging, treatments, and outcomes. And it's a way for us to share our patients across the country to ask questions of these rare diseases. So the nice thing about this is that it fosters collaboration, and so this data belongs to all of us. So if you refer patients to the vasculitis clinic and you have a pressing vasculitis question, you can actually appeal to all of the CanVasc members to share their data in an easily formatable way. So that's one of the current research benefit of sending people to the vasculitis clinic. Natasha Degan is also recruiting for the ABATACEPT study. So this is a study looking at ABATACEPT for the treatment of relapsing non-severe GPA. So still actively recruiting. So these are non-severe relapsing Wegener's patients over age 18, and they get randomized to ABATACEPT sub-Q versus placebo, and they still get their maintenance therapy. So they're still getting standard care. Patients who experience a relapse or are not in remission by the 6-month mark can receive the Orencia open label. So if you have any patients that you think qualify, please refer them to Dr. Degan. And thanks for listening to me. I'm happy to take any questions.
We have lots of people on. Any comments? Oh, we had a comment from Dr. Murphy, by the way. They struggle with temporal artery ultrasound here at St. Paul's, not just site dependent, but also tech dependent. They have 12
Yes.
techs, and given the relatively low numbers, it's hard to clean up everybody, and maybe a few targeted sites in each city, which I agree with. Right now, we funnel them to Dr. Bardi, who does it, and I think he's going to be overwhelmed pretty soon. So it'd be nice to have a couple of sites where we can funnel these patients, because we need to get the ultrasound done relatively quickly. What are your thoughts?
Yeah, thanks, Corrie. It was great, Grant and Cam, for mentioning that. I mean, I think that at St. Paul's, certainly we would like to do more of these and do a better job. The problem, as I mentioned, is that what we should really do is get a couple of techs trained up, as Natasha mentioned, and just have 2 or 3 techs in our department that are very comfortable doing them. We do that for other things as well, for in other areas of not just MSK ultrasound, but ultrasound in general, orbits and things like that. So that's what we should do. And Mo was very good and gave us a great grand rounds earlier this year, I think, or maybe even late last year. I think it was earlier this year. Superb rounds on ultrasound. So, I guess the challenge becomes it's the balance between getting, Mo's doing a lot of these cases himself, which means we get less of them, which means we see less of them, and it's a kind of knock-on effect. But having said that, I can see why he does them when he's the one that is doing lots of them by volume. So it makes a lot of sense. We should take this on, obviously, further as a potential project to improve how we do them. And I'd urge you in Victoria as well to do something similar, to try and liaise with 1 or 2 individual radiologists who are interested in try and develop your program with the team there. But it's hard because these are typically, they present to a GP perhaps first line, and then they order the ultrasound, and it goes to a community imaging clinic that maybe doesn't have the experience. And so how to centralize these is really important. Your comments on PET were interesting. I think it's public knowledge now, but we've had a donor, a big donor for the new St. Paul's for a PET-CT, which is huge, and it'll be potentially the first or at least non-dedicated oncology PET. A lot of work that needs to be done in terms of how that is rolled out, but it's looking more and more certain that the new St. Paul's will have a dedicated PET-CT, which will be, I think there's a lot of non-oncology applications that we can do as well as the oncology applications. Obviously, all the cancer that comes through here will be great, and rectal cancer and all of the other things that we do. But I think in terms of cardiac PET-CT, of vasculitis work that you guys do so much of, things like neurodegenerative diseases, that will be fantastic. So it'll be fantastic once we kind of get there. But there's, as you mentioned, there's things like within the provincial government to try and to make sure that this happens, including it's not just the cost of purchasing the machine, it's the running costs and the maintenance and billing codes, all that goes with it. So a lot of work to do.
Thank you.
Apply to the Facility Engagement Fund to help support at least the development process.
Yeah, good idea.
Yeah.
Any other
That's what I plan to do in Victoria.
Any questions? I'm particularly interested in nephro and RESP. Any neuro questions about GCA? It's it's one of the conditions, Corrie, that you have. You feel so great treating, and when things go bad, you feel terrible. People go blind, they have strokes, they're missed in emerge, or they're missed by us, and it's a frequent M&M rounds in rheumatology is the adverse events in GCA, and of course the steroid side effects.
And the steroid side effects, I think, are really underplayed, because typically they're started on steroids and then referred to us, and by the time we see them, they're having all the complications of the steroids. And these are elderly people; they don't tolerate them well.
Exactly.
Well, thank you.
Before I thank Dr. Baldwin, next week's Grand Rounds is Dr. Jagbir Gill, and it's titled Implementing Patient-Focused Changes to Healthcare, the Bridge to Transplantation Initiative. So look forward to seeing you then. Corrie, excellent rounds and a beautiful family on this last picture. Thank you for stepping into our grand rounds here at PHC. Appreciate it very much. Look forward to your future work and collaborations.
Thank you.
Thanks, everybody.